We're going to start off with Dr. McBride and just a brief introduction. Dr. McBride is the Grace Crum Rollins Chair of Behavioral Sciences and Health Education at Emory University's Rollins School of Public Health. She also serves as the Associate Director for Community Outreach and Engagement at the Winship Cancer Institute. She'll be presenting on, the title of her talk is Addressing Disparities in Access to Genetic Services for Hereditary Breast and Ovarian Cancer. And take it away, Dr. McBride. Thank you for speaking today.
I just wanted to acknowledge the folks at Winship and at Emory and my partners, community partners, and trainees who've made all this work happen. So thank you. Next slide. So as you heard, I hold the role of the Community Outreach and Engagement Associate Director at Winship. As of 2016, the NCI started to upgrade their expectations around community outreach and engagement. And they had this 4-item specific mandate for community outreach and engagement activities. I'm going to go forward calling them COE. One, show evidence of how community COE was reducing cancer burden, particularly among minority and underrepresented populations, to make sure that our research was aligned with what were relevant problems for the catchment area. And in our case, the catchment area is the state of Georgia. We were also charged to work with, to address sort of the catchment area needs by partnering with community organizations to develop a community advisory board, to work with healthcare systems in the communities and state and community agencies. And then also to demonstrate that we have disseminated evidence-based learning or evidence-based findings to these communities. So next slide. When I took over in April, we started this office, Denise Ballard and I, in April, we were building on a very strong and deep reputation of community activities through Winship, Rollins, and the medical center. As you can see here, we already had a lot going on across the state related to smoke-free homes, HPV vaccination uptake, hereditary breast and ovarian cancer screening, which I'll talk about, cancer treatment consent literacy, some of Becky's work, tobacco cessation program in all of our clinics, Cancer Quest, an online resource for community educators around cancer biology, pediatric cancer survivor link to link pediatric care to adult care, and cancer screening for HIV positive. So we have a great foundation to build upon. The office, next slide, the office now has chosen to organize itself around this notion of community partnerships, and with the thematic areas of risk factor reduction, access and accrual, and co-learning and dissemination. Risk factor reduction includes screening, access and accrual as relates to clinical trials and population studies. And what in the idea we're looking for are synergies in these areas. And as I've highlighted here, the synergy that I'm going to be talking about today is highlighted in yellow, and it's the risk factor reduction intersection with access and accrual. Next slide. So I've taken the liberty today, since it's related to the 2 talks before Becky related to hereditary breast and ovarian cancer, to bring the work we've been doing, my colleague and I, Yu Guan, in our precision public health program. And in much of what's happening in genomics, the thinking is that the advances are going to allow us to do risk factor stratification and better target health promotion, disease prevention, treatment interventions based on this information. Next slide. In the area of cancer screening, breast cancer screening, simple tools like family history algorithms can be used to stratify populations on cancer risk. So next, if you just advance. So that can divide our samples into those, identify that sort of smaller population, the population who are at greatly increased risk, and refer them to genetic counseling and testing available options. also not listed here is access to their family members, so their family members are aware of their high genetic risk. Next. But what we see is that almost all of this is happening in cancer centers, tertiary cancer centers, which are often not as easily accessible to minority populations. And when we look, most of the data that we see on uptake of genetic testing and counseling among African-American settings is significantly lower than white patients. Next, just advance again. We can also importantly identify a very large group of individuals who are at low genetic risk, meaning that their general population risk, they may not require as much surveillance, and that could decrease healthcare costs. And this sort of in general, writ large, is considered to be precision public health, and sort of the vision genomics might be going. So in the area of hereditary breast and ovarian cancer, if we go to the next slide, the genetic efforts to try to take genetic services outside of clinical, these tertiary cancer centers. And most of that has been envisioned through telegenetic outreach. So genetic counselors who are doing these appointments via telephone or video. But what we have seen is that that has still not greatly decreased or greatly decreased the numbers of African Americans. In this case, this study, which was conducted at Georgetown, was largely African American and white, has not succeeded in decreasing or increasing uptake. And when we drill down, it's very interesting because it's sort of a we have to keep in mind both disparities being really inequities where there should be equity, and separate that notion from differences in preferences. And there's often a confounding of the two, and actually probably both are present in some of what we see as differences in uptake of genetic services. If you just advance to the next, when they drill down in this randomized controlled trial, what they found is that this was a non-inferiority trial where the goal was to show that telegenetic outreach was not inferior to face-to-face genetic counseling. And what they found is that in the usual care, which was face-to-face genetic counseling, there was no difference, no racial ethnic differences. But amongst those who received the randomized to the telegenetic counseling, African Americans were less likely to take up genetic services after the telegenetic outreach. So even when we try to increase our reach, we may not be fully understanding what the needs are of the population, of the African American population that we're targeting. The second area of challenge is related to reaching family members in this high risk category. So if you go to the next slide, the technique that's typically used is what we call cascade screening. And cascade screening is when the individual patient is tested and found to carry a mutation in BRCA1 or 2 or another mutation. Those individuals, by virtue of ethical requirements, are tasked to inform their relatives. They're usually provided with written print materials that they provide to their relatives, and then that relies on them reaching out to their relatives, disclosing that they have been diagnosed to have a genetic mutation, give the information to the family member, and what we see is very high levels of incomplete disclosure. So another leak in the pipeline. Then in turn, the relatives who have been disclosed to are then have to reach out to services themselves and get counseling and testing if appropriate. And again, we see another area of incomplete uptake. So collectively, if you just advance again, collectively, what you see is that less than half of family members who could benefit by knowing early that they are a gene mutation carrier and may have available preventive services that they could access do not do so. So these two sort of areas of challenge have been an area that we've been focusing on. And we have in sort of exemplifying our approach of using community partnerships as a centerpiece. If you advance to the next slide, we have pursued a number of partnership opportunities. So we are working with Horizons Community Solutions. This is a partner, a longstanding partner that has worked with many of us in Winship and in the School of Public Health. They are in Southwest Georgia and have ongoing services in cancer prevention and early detection. We also can partner with Georgia for their ongoing family history assessment in public health districts, where they are offering family history screening and genetic counseling and genetic testing free of charge. Low risk but they've been the reach of that program has been fairly low, with less than 1% being screened currently. We also have, as you heard from Kevin, the State Cancer Registry, where we can take advantage of ongoing contact with cancer survivors, and that can be an opportunity for us to extend reach to family members at high risk. And then lastly, we have the Emory's Genetic Counseling and Training Program. Right now, we have a very serious deficit of genetic counselors across the country. And so thinking about ways to extend these individuals is going to be very important. And working with their training program with genetic counselors and training could be a way to extend these services. So moving to the next slide. So partnering with these 4 organizations, we have come up with 2 research studies that have been funded by the National Cancer Institute to try to do better at understanding what is getting in the way of uptake of genetic services. The first one, and they're both using what I would consider novel and certainly new for the US, not necessarily, or at least new in this context, new approaches. The first is a study to understand African Americans' perceptions of the benefit of hereditary breast and ovarian cancer genetic services. And this is using a technique called citizen juries that I'll talk about, and deliberative democracy, and I'll talk about that in a minute. And the second study is with expanding reach of genetic services to blood relatives of ovarian cancer survivors, and that is using citizen science techniques. Both of these are intended to democratize knowledge such that we are actually involving in a deeper way the populations of the citizens that we are the target of our interventions. Next slide. So the first study, just to give you a little bit of detail, we're calling the Southwest Georgia Council on Hereditary Breast and Ovarian Cancer. This is the deliberative democracy study that we are partnering with Horizon Community Solutions in Albany, Georgia. The deliberation question is that we will be posing to a citizen jury is, should hereditary breast and ovarian cancer screening efforts in Georgia be accelerated among African Americans due to some of the disparities in survivorship from breast cancer among African Americans? And what this does is we conduct a 2-day now virtual deliberation where we have 20 to 30 citizens participating, where they're airing differing and often conflicting viewpoints related to the question, and they are charged to deliberate on what is best for the common good using preset evaluative criteria. How this is different from other standard qualitative things like focus groups and so forth is that they become quickly expert in the question at hand. So they will view pre-recorded brief expert testimonies. The testimonies are about 10 minutes long. They cover a variety of the central elements that they need to understand to think about this question, things about how hereditary breast cancer in African Americans, why do population screening, what are the steps in genetic screening, what's the role of ancestry, and the common good. They gain the knowledge, they're able to talk about and challenge and ask questions, and then they move into their deliberation sessions. We record the sessions, we code the sessions, and we can generate the data from that. Then they vote in small and large groups with the charge that they are to arrive at consensus on a recommendation. Next, could you just advance again? And so the deliberation partnerships are recruited in partnership with community organizations in Southwest Georgia, and they are going to represent the constituencies of citizens living in that area. Next slide. So what do we do with this? How is this helpful? So after the deliberation, when you have 25 or 30 people giving their viewpoints on the pros and cons, their insights into how the evidence is setting with them, in their ultimate conclusion, we then do a large validity check via a representative survey to see if these stand up when we survey a larger number of individuals. With that information, we can engage policy stakeholders to consider actions that they could take. And in parallel, we can be developing interventions of the citizen viewpoints to increase uptake of genetic services where appropriate. Next slide. So the second study that I wanted to talk about is the Your Family Connect study. This is a study being conducted in collaboration with Georgia Core and the Georgia and the Cancer Registry. And in this, our question is, how do we get survivors of ovarian cancer and their close relatives to visit a website to learn about global genetic services? Our key task here is getting to the relatives. And the benefit of ovarian cancer is that the current recommendations and guidelines are that anyone who has a close blood relative with ovarian cancer should undergo at least genetic counseling. So this allows us to offer survivors different approaches to contacting their relatives. They don't have to shoulder all of the responsibility to contacting the relatives, though we know they will have preferences to contact some, and in some cases, maybe all, we can offer to assist. And so in this case, we're in the next slide, please. We're using a citizen science approach. Citizen science has been used a lot in the environmental sciences, but very little in the health sciences, promotion, and disease prevention. And next, just advance again. So what the citizen scientists are charged to do is we give them tasks to collaborate with us on. And these are just examples to help us identify the steps of contact that would motivate a survivor to seek new information via the website, to collect perspectives from how they shared within their families using different qualitative and quantitative methods. We provide the data collection tools. Next, advance again. We provide the data collection tools. So we provide them survey structures for doing surveys online, structured interviews, online panels. Next slide. And we provide them technical support to partner with them in terms of we have pre-recorded training. We have coaches that meet with them weekly. We have question banks that they can choose from to develop their survey, and they work with us to do that. And then we also help them with survey development and survey and interview development. Next slide. So right now we have 14 participating citizen scientists. They live all over the country. There's 8 states represented, and they are collecting data through 7 ovarian survivor foundations, a far broader reach than we would have been able to do in a qualitative assessment. And indeed, we are not able to access many of these ovarian survivor listservs and foundations because we are not survivors. Next slide. After the data is collected, what do? Well, we work with the citizen scientists to help us interpret the data. They participate in operationalizing elements of the intervention. They review drafts of the intervention, and they help us write and disseminate, write up the results and disseminate in great and peer-reviewed literature. So their voices are thread through all of the research steps. Next slide. Did we get stuck, Julie?
Not on my end.
Okay, must have been my little, sorry about that. So I think it's really important for us to think about the fact that if we're going to address disparities, we really have to think and maybe even challenge our research paradigm, which tends to be a bit on the linear side, where we see understanding as sort of an upstream thing that where we need to clarify all of the basic science and get that all lined up before we can then inform prevention and treatment. And if you just advance for a minute here, I think that what the community outreach and engagement, the Office of Community Outreach and Engagement research that I presented here is showing, you advance for me, Julie, is that we really we really need to involve the community end user in all phases of research so that we're not getting to the end where we see that we have these great genomic tests and such, but we have poor uptake and we inadvertently foster disparities. So with that, I will stop and thank you very much. And I'm sorry for all the technical difficulties today.